introduction to the HOTCASE for the CICM Fellowship exam.
So this is a key document that all of you should read. Uh, it tells you about how much is a pass mark in the exam. And we know that for the hot cases, the pass mark is about 15. And for the cross-table vivas, it's 20. And these are the objectives. So it is very clearly given what is expected from a candidate. So the candidate should be able to perform an orderly, purposeful, and relevant sequence of assessment of a system, a part of the body, or those parts of the body involved in a local or general problem, carry out correctly the assessment of each potential clinical sign, derive an acceptable diagnosis, not necessarily the correct diagnosis. I repeat, it's not necessarily the correct diagnosis because the candidates just keep thinking that they have missed a diagnosis, but it's not necessarily the correct diagnosis that you should get. You should derive an acceptable diagnosis and provide relevant differential diagnosis. If requested, candidates are encouraged to defend the method of eliciting a clinical sign, and they should be able to briefly request, they should also be able to briefly interpret the relevant investigations that are provided to them and discuss an appropriate management plan, including priority for setting for that patient, and define ethical problems in the patient's management. So throughout, and the other important thing is throughout the interaction, the candidate should display courtesy and consideration for the patient and the ICU staff caring for the patient. So essentially it tests your clinical or the bedside skills and how you put information together and come up with the management plan. That's the main aim of the HOTCASE examination. So one of the other things that I try to tell everyone is what is a finding in the clinical examination. So the finding can be anything that is inside the patient cubicle. So it can be the equipment being used or not being used. It can be the purple bins that are there at the bedside, the cytotoxic, CPAP machine that the patient is probably not using when the patient is intubated, drains, pumps, both which have got the labels with the infusions that are running and the infusions that are not running, and any clinical sign that you find on examination of the patient. Is decreased air entry, bronchial breath sounds, murmurs, any drain tubes that is inserted in the patients. All of these constitute a clinical finding at the bedside. And we start, there is a 2-minute time for the candidate to process the information that is provided to them. No, don't worry, you will have a printed sheet given to you, which will specifically ask you to perform specific examination. And usually the candidates start with an end of the bedogram, and I would suggest that you should spend less than 3 minutes at the bedside, and then go and perform a clinical examination, because clinical examination takes a significant amount of time. So don't spend too much time just doing the end of the bedogram. And try to, when you're doing the HOTCASE practice, try to finish the examination, including the end of the bedogram, in 8 minutes, if possible, because that's a very key skill. It will give you additional buffer in the examination, because examination will always be in another hospital where you might require a bit more time to gather the information. Expose the patient properly, and think about what is the first system I'm going to examine in the patient. For example, if it is a neurology that you're going to examine in the patient, neurological examination can take a very long time, and you may not have enough time to examine the patient's cardiovascular or respiratory system, whereas the case might have, they may not specifically ask you to do a neurological examination. They might just say, examine the patient. So if you start with the neurological examination and you don't have enough time left at the end of it to do a detailed respiratory system, you will probably miss all the findings relevant to the respiratory system. And try to practice in a way that doesn't appear in the examination that you're thinking while you're performing the examination. Uh, and it should be a very smooth flow at the bedside while you're performing the examination. And avoid rough handling of the patients. Especially don't move their limbs or don't bend them without asking for whether I can move the patients or not, because sometimes the candidates have failed because they haven't been courteous at the bedside. So and then the discussion time, it's about generally 10 minutes. It can be longer if you finish the examination early, then it can be longer than that. And it is usually held away from the patient bed space, but be mindful that we are doing this examination in a busy ICU environment where there will be some noise in the background. So it's not a quiet corner. It can be as quiet as possible, but it will not necessarily be a closed room. It will be in an open space and in a quieter area of the intensive care unit. Candidate presentation, I would suggest that you should always aim for less than 5-minute presentation, depending on the case. Obviously, a patient in whom you have to talk about all the issues pertaining to the patient's management. In a patient who has been in ICU for, say, 21 days, there will be a lot to talk about. So I would suggest that whenever you present your findings and management plan, try to complete it in 3 to 5 minutes time. Then there will be in the questions or the discussions that the examiner will have with you, there will be an interpretation part where they will give you an arterial blood gas or an ECG, or show you the blood test results that the patient has had recently, or an imaging investigation. So it includes X-rays, CT, or echocardiography loops. And then that takes about 2 minutes. And then the remaining time is questions that the examiners have prepared in advance for the candidates. And the examiners may or may not ask any clarifying question. If they feel that they just didn't hear you mentioning something, they might ask a clarifying question. It doesn't mean that you have necessarily bungled up the case. It just means that the examiners haven't heard, or the examiners just want to clarify a point in your presentation. And then when 20 minutes is up, it's the bulldog who notifies, and then the examination finishes. So these are some of the common themes that we have as questions in the examination. So weaning from mechanical ventilation is a big one. Identify relevant issues for the patient management in the 24, 48 hours or 3 days, and outline a management plan. Why is this patient febrile? So essentially the cause for fever. Examine the respiratory system and identify the cause for respiratory failure. Same with cardiovascular system, and identify the causes of shock. Examine the neurology and provide a differential diagnosis for unconsciousness. How would you prognosticate in a patient with traumatic brain injury, out of hospital cardiac arrest patients, or a patient with stroke, abdominal examination. They can be a patient with a trauma laparotomy, open abdomen, or a complex abdominal surgery with multiple drains. So how would you manage the patient? Examine and find the cause for oliguria in a patient who is in renal failure. Spinal case, if the patient has got good neurology, they will definitely be kept. And spinal case will not necessarily mean a patient with the spinal trauma. It can be a patient with the complex aortic surgery who has had spinal complication like spinal infarction. So you need to be uh, aware, or you need to think about those things as well. So perform a secondary survey or tertiary survey after trauma. That's another big topic in the hot case. So these are some of the common, not necessarily an exhaustive list of the things that will be asked in the examination, but these are the common themes that you have to be preparing for. So the 2 minutes time that you have, you think about the system which you're going to concentrate on, and think about, for example, if it's a weaning patient, what are the things I'm going to look at in a weaning, in a patient with weaning? Ventilator settings, patient's muscle strength, whether the patient is cooperative, whether the patient is able to deep breathe. All those things you will be looking at. So you go through that in your mind. And what are you going to, how, and you, during the preparation, I would strongly suggest that you should try and come up with your own template and in your mind. And on the day of the examination, when the question is provided about weaning, then you put those relevant things that you find on examination in that template, and present the findings